implants and splits. First, digital occlusal analysis for comprehensive bite assessment.
دكتور ممكن تعيد بس لأني ما كنتش شغل الريكورد أخذت البرميشن وما اشتغلتوش بس عيد من كأنك بأول ما بدك تبدأ. تفضل.
Hi everyone, today I'm going to talk about current topics in prosthetic rehabilitation and occlusion. And this is my topic list. First, I will talk about digital methods in occlusal analysis, then a little bit about electromyography and neuromuscular dentistry, and finally, I will discuss case reports that involve prosthetic rehab for special needs, multidisciplinary work, implants, and splints. First, digital occlusion analysis for comprehensive bite assessment. As you know, dental occlusion, or the static relationship between the masticatory surfaces, is a critical component for diagnosing and executing prosthodontic treatment plan, using either conventional or digital methods. Regarding the digital methods, different technologies have been described to capture occlusion and mandibular motion. These include intraoral scanners, digital jaw tracking systems, computerized occlusal analysis systems. First, we'll talk about the scanners. As you know, dental scanners can integrate the individual scans of each arch individually with the buccal scan that represent the max intercuspation. And this integration will result in virtual articulation, as you can see in these two examples. The first example is a Trios 3-shape, and the second example is iTero intraoral scanners. And they both work in the same concept. Two individual scans for the arches and buccal scan that represent the max intercuspation, both integrated to produce this virtual articulation. Intraoral scanners versus conventional articulation. Shadid and Sadaka in 2022 conducted a systematic review about the accuracy of static articulation, whether teeth or implant-supported restoration, and concluded that both techniques were comparable. They also suggested that there are several factors that might affect the articulation accuracy. These include articulation technique, characteristics of the virtual occlusal records in terms of number, dimension, and location, length of the digitized arches, presence of edentulous areas in terms of position and size, and the used intraoral scanner technology. Now, regarding the effects of number of teeth on the accuracy of intraoral scanners, Ravella, Leon, and his colleagues in 2022 assessed the influence of the number of teeth, 2 or 3 or 4 teeth, on the articulation accuracy, and found that bilateral occlusal records that involve 4 teeth obtain higher maxillomandibular accuracy than bilateral occlusal records that involve less than 4 teeth. Therefore, in other words, when possible, they recommend to include at least 4 teeth on the bilateral occlusal record that captured by the intraoral scanner. Effects of PDL plasticity on the accuracy of intraoral scanners. Ravella, Leon, and his colleagues in 2021 suggested that the PDL plasticity have an effect on the articulation accuracy called occlusal collagen or mesh interpenetration. First, let me show you a picture of the occlusal collagen before I read the definition. Look at this figure. As you know, first we scan each arch individually, and this scan will have the teeth in undisplaced position. But when the patient bites for the buccal scan, the teeth will be displaced in more inferior position. As you know, PDL can be displaced around 100 micron. So as you can see in the second figure, these pink areas represent the difference between the displaced position and the undisplaced position. back to the definition. So Ravilla-Leon defined this occlusal collision or the mesh interpenetration as a discrepancy that results from PDL plasticity between recording intraoral digital scans of the maxillary and the mandibular arches and the virtual occlusal records. However, dental literature analyzing the influence of intraoral scanner technology on the presence of occlusal collision is scarce. Now, what is the significance of this occlusal collision? If this occlusal collision left uncorrected and the restoration fabricated in that displaced position, this will result in under-contoured or non-contracting restorations. In order to solve that, in attempt to solve these problems, some intraoral scan provide correction for the occlusal collision, either by eliminating the interpenetrating area or by suggesting opening the maxillomandibular relation until the interpenetrating area disappears. In other words, opening or raising the bite. For example, this scanning system software, MEDIT software, as you can see in the first figure, MEDIT software provides correction for the occlusal collision. There was no occlusal collision. The second figure, which represents the TRIOS software, the TRIOS system, the occlusal collision remain uncorrected. However, the evidence about the effect of these corrections on the articulation and the resulting restorations is still lacking. In the review, they considered this part to have a huge knowledge gap that need to be studied. Effect of interocclusal space on the accuracy of intraoral scanners. Onses and his colleagues in 2021 evaluated the effect of different interocclusal spaces 0, 1, 2, 3, and 4 degree interincisal opening on the articulation accuracy. And the results showed that the greater the interocclusal space, the higher the accuracy of the maxillomandibular relationship measurements. In another word, the less overlapping between the maxillary and mandibular dentition may favor more accurate alignment or articulation. Second topic about digital jaw tracking systems. Jaw trackers can be classified according to their functional capabilities that the system offers. First type, the diagnostic system, which means only for the data acquisition and data analysis. And the second type is the diagnostic and designing systems, which means it's integrable with the CAD softwares. Now, both can track the mandibular movements, but the main difference is that the diagnostic and designing system allow exporting the mandibular movements into CAD/CAM devices, while the diagnostic systems do not. Now, Ravilla-Leon and his colleagues in 2023 reviewed the currently available tracking systems, and these systems are shown in the following table. Now, these are two examples of diagnostic jaw tracker, the JT3D and the K7. Both work by magnetometry. This system simply composed of mandibular tracker, usually come as a biting fork, and a mounting head frame. And as we said, no CAD involved in these systems, which means you can't use it for designing. And the next two slides show 10 examples of the diagnostic and designing systems. Their technological mechanisms usually work by photometry, magnetometry, ultrasound, or may come as infrared optical systems. This table also summarizes their components. And as we said, CAD software can be integrated with these systems. As you can see, this jaw tracker work by photometry. This is an example DMD system work by magnetometry. and these two by ultrasound system, and the last one come as infrared optical system. Now, in the next few slides, we'll take representative examples from each mechanism to understand how they work. First, the ultrasound tracking system. This figure represents the GMA tracking system. Regarding the components, the ultrasound emitter array is bonded to the labial surfaces of the mandibular teeth, and the sensors are located on the head frame secured to the patient head. So, this system determines the mandibular relative position by calculating the time for the ultrasonic pulses to reach from the emitters to the collector sensor, from the emitters to the collectors in the frame. And as you can see in this tracing graph, it gives you these numbers. These numbers represent the distance of movement. Also, the relative position of this red dot to the center, which represents the direction of movement. The limitation of this system is the sensitivity to environmental noises and temperature that might affect the positional accuracy up to 0.1 millimeter after calibration. Second example, infrared optical camera tracking system. This figure represents the GMA optic tracking system composed of a head frame that hold two cameras and the lower jaw sensor that come as a biting fork. So when the mandible moves during a measurement, the movement of this sensor that attach the mandibular teeth recorded by these two cameras that's integrated with this face bow or with the head frame. Photometric tracking system. This figure represents the 4D motion capture system. It's almost the same concept as the GMA optic system, but instead of using mandibular sensors or biting forks, this device uses markers that can be detected by a camera that are mounted on the head frame. So this system uses one or more cameras to track position of the markers fixed to the mandible with or without additional markers fixed to the face. After that, it will give you this tracing. Regarding digital jaw tracking accuracy, Farouk and his colleagues in 2022 conducted a systematic review about variables that might affect the accuracy of the digital tracking systems, and concluding that realistic variations in device accuracy were found between 50 and 330 micron across the digital systems, with a very low inter-rater reliability for motion tracing from photographs. Regarding the variables that might control or affect the jaw movement, mandibular and condylar growth, dysfunction of neuromuscular system, shortened dental arches, previous orthodontic treatment, variation in habitual head posture, temporomandibular joint disorders, and to a limited extent, parafunctional habits and unbalanced occlusal contact were identified as confounding variables that shape jaw movements. Ravella, Leon, and his colleagues in 2023 compared the accuracy of 4 intraoral scanners, Trios 4, iTero, i700 Medit, and PrimeScan with digital tracking system, which is 4D motion capture system, and found that the maxillomandibular trueness values from high to low, iTero, associated with the highest trueness, followed by the digital tracking system, followed by Trios 4, followed by PrimeScan, followed by i700 Medit, which associated with the lowest trueness. And the only significant difference in trueness was found between iTero and both i700 Medit and PrimeScan.
Majd, I have a question. Uh, in the previous slide, they compared the maxillary mandibular relationship, or يعني, what they compare between these intraoral scanner, the accuracy of what يعني.
Trueness to the a conventional control.
Yes, regarding the maxillary mandibular
Articulation
relation,
accuracy.
the
Articulation
occlusion,
accuracy. No.
articulation. Okay, okay,
Yeah.
okay.
Now we'll talk about the computerized occlusal analysis systems. Different computerized occlusal analysis systems have been described for detecting occlusal contact. This table shows you the three available systems, their function. As you can see, the occlusense used to measure the static and dynamic occlusal contact in terms of pressure and timing. Same for Okera. T-scan only measure the static occlusal contact, pressure and timing, not the dynamic, but also measure the total bite force in Newton. This table also show you the different sensor used in terms of sizes and thickness. You can see that the smallest thickness used in occlusense, the Okera has the highest thickness, and T-scan in between. Now we'll talk about T-scan in details. In 1984, T-scan developed T-scan version 1, which was the first ever grid-based sensor technology precisely designed for occlusal analysis. And this figure shows the different generations of T-scans over the years. There are 5 generations, as you can see. Until now, the advancement is reached up to version 5. This figure will give you an idea about the T-scan simply composed of the sensor, the present in this biting fork, the handle assembly, the system unit, the computer software, and a printer. Regarding T-scan sensors, the sensor is the key component. It has 60 micrometer thickness and made of a polyester film. T-scan sensors are available in 2 sizes. The large size, as shown on the right side, accommodates arch up to 66 millimeter wide and 56 millimeter deep. And the small one, which shown in the left side, accommodate up to 58 millimeter wide and 51 millimeter deep. Regarding calibration, the sensor is made of columns and rows of pressure-sensitive ink. So when the patient bites on the sensor, the handle scan and reads the data from the sensor and pass it to the computer software, which present the data in an easy-to-understand visual display. As you can see in this figure. Now, the program can be operated in 2 modes. Force analysis. This mode offers the operator with data on the location and relative force of tooth contact. And within the force analysis, there is also 2 additional modes. First one is the instantaneous, which registers the mandibular position, and the sequential, which registers the intensity of contact during mandibular movements. The second mode is the time analysis. This mode gives information on the location and the sequence of occlusal contacts, showing in a different color the location of first, second, third, or more contacts along the contacting period. In this figure, represents the color fringe, as you can see. Each color coded for a different amount of force. The warmer the color, the taller the column, and the greater the force. Recording technique. The recording handle with the sensor and arch support is placed between the maxillary central incisor aligned with the dental midline. The recording is initiated by pressing the bottom on the recording handle. The patient is asked to close the mouth till complete intercuspation is reached, but without making any excursive movements. After the handle bottom is pressed, the arch model is automatically created on the screen. Regarding the software components, as you can see, there are several components. The most important components are these three: the 2D and 3D force windows, the occlusal timetable, and these graphs. Now, the 2D and the 3D force windows represent the occlusal data with colored column, ranging from blue, which represent the optimum force, for example, like this one, to the red, which represent a high force, like this one. And these columns will show on the screen once the patient bites on the sensor. So, in other words, these windows, the 2D and 3D view windows, are like the articulating papers that show you the amount of force or the intensity of the force. Now, regarding the occlusal timetable, and these graphs will give you the contact details in different time along the contacting period. First second, the second second, the third second, the amount of force. And you can also play them in a video using this button to show you the amount of intensity force during different time period. And we will see the significance of this in the next few slides. Now, how do we interpret the data for occlusal adjustment? As you can see in this figure, there is a diamond shape. This diamond represents the center of force at a given time. And this tracing of the red path represents the path they moved, the path that the diamond moved during registration, which means you can know where the earliest contact or the interference is and adjust it accordingly. So by gaining information, the earliest contact, it can be adjusted and simultaneous contact can be achieved. Using, of course, the occlusal timetable, using the graphs. T-scan benefits: improved diagnosis, increased quality of care, decreased treatment time, because adjustment real time eliminate the need for mounting the models on an articulator. Increase comfort of dental prostheses, reduce risk of implant failure, traumatized teeth, unstable dentures, ineffective splints, and porcelain fractures. Legal documentation of the outcome, and enhance patient education. Regarding the limitations, there are several limitations for the T-scan. The thinner occlusal registration material provide more stable record of the contact points. But in T-scan sensor, to fulfill this technological demand, this sensor made as thin as possible, up to 0.1 millimeter, which is still thicker as compared to the occlusal indicator, such as articulating paper. Second limitation, the sensors may be damaged when forces are concentrated over a small area, such as sharp tooth cuts, and this may lead to inexact recording of occlusal contact, or may produce artifact in the produced images. Third one is that the T-scan system is able to duplicate occlusal interferences only exceeding 0.6 millimeter in dimension. And the last one, the two unlike modes of the system, the force and time analysis mode, may mimic different occlusal contact data. Computerized versus conventional occlusal analysis. Diaz and his colleagues in 2020 compared the accuracy of the occlusal analysis between digital and the conventional methods and concluded that computerized occlusal analysis provided a reliable method for measuring occlusal contact at maximum biting force. However, the conventional techniques seem to provide the highest reliability and validity for measuring occlusal contact. Now we'll talk briefly about electromyography. Electromyography is a technique that have been used to evaluate and record the electrical activities that's produced by skeletal muscles and perform using an instrument called electromyograph to produce a record called electromyogram, as you can see in this figure, using only a software or a computer and two or more electrodes on the skeletal muscles. There are several applications for electromyography in dentistry. First one, intraorally, used to measure the action potential in actively contracting lingual and masticator muscles. As you can see, they use the two electrodes, for example, on either the lingual muscles or the masticator muscles. And then the electromyograph will be used to analyze these muscles. Second, to evaluate the biomechanics of the jaw and facial muscles functions. Also for the management of myofascial pain dysfunction syndrome and its procedure called auditory or visual electromyographic feedback. Additional uses, for example, to monitor bruxism, asymmetry in muscle action, and postural disturbances. Has been suggested by Kirstein that one etiological neuromuscular mechanism that explains the association between hyperactivity of the masticatory muscles and long disclusion time is the longer the excursive interferences, the longer the periodontal ligaments are compressed, and the longer, therefore, the masticatory muscles are activated to contract. Based on this finding, Depp and his colleagues in 2015 measured the effect of shortening the protrusive disclusion time and the balancing the center of occlusal forces on electromyographic recordings. Also, for assessing the pain reported by chronic patients 1 month after computer-guided occlusal adjustment using T-scan. In other words, they combine the use of T-scan for adjustment with the electromyographic analysis to remove these interferences. They concluded that combining electromyography with T-scan for occlusal adjustment is able to reduce the activity of the masseter and the self-reported muscular pain of patients 1 month after treatment. 1 month after treatment. As you can see in this table, they reported the right and the left masseter muscle activity. They also reported the disclusion time in second. You can see there is a correlation between the disclusion time and the muscle activity. When the disclusion time were reduced, for example, from 1.8 to 0.6 seconds, the muscle activity for both the right and left masseter muscle also reduced. And again, this was done using T-scan adjustments and electromyography. Now we'll discuss two case reports that involve customized prosthodontic solutions for patients with special needs. First case about amelogenesis imperfecta, conducted by Rajaman and his colleagues. This case is about a 22-year-old male patient with chief complaint of yellow to brownish discoloration of all teeth since 10 to 12 years. Upon clinical examination, patient had a complete set of permanent dentition, no missing teeth, no chipping of enamel, and a soft enamel structure. Treatment plan was to provide structural support as well as provide excellent aesthetic. So a full crown restoration of the entire dentition was advised. Lower left first molar was grossly decayed, and hence it was extracted. The choice of the material used for this was zirconia coping structure layered with ceramic for the maxillary and mandibular arch, owing to the severe discoloration of the dentition. Treatment progress, the first visit, centric relation record done by a manipulative technique, and vertical dimension at both wrist and occlusion was determined. Impressions for the upper and lower, and mounting on the semi-adjusted articulator using this record. After that, the impressions were scanned, then diagnostic wax-up was done, as you can see in this figure. After that, from the diagnostic wax-up, they did mock-up. Gross tooth preparation was done through this mock-up, shade selection, and the provisional restoration that inserted in the mouth, they were milled from PMMA and then adjusted to achieve anterior guidance and a perfect exclusion on the posterior teeth during protrusive movement. Finalization for the tooth preparation. After that, took impression for the upper and lower preparation with PVS. Temporization for the prepared teeth. And of course, after adjusting the provisional restoration, they did a new record according to the adjusted occlusion. The fourth visit, designing the restoration. Of course, the